بسم الله الرحمن الرحيم. Lung transplantation. Lung transplantation was first performed successfully in 1980 and offers benefits in both prognosis and the quality of life to select patients with end-stage lung disease. The number of candidates for transplantation continues to increase, and there is a significant shortage of donor organs, and so an increasing number of patients die on the waiting list. There are five United Kingdom adult lung transplant centers, including Birmingham, Harefield, Manchester, and Newcastle and Papworth. Matching is carried out according to patient size and the major blood groups. Human leukocyte antigen HLA matching is not performed. The underlying conditions, most common underlying diagnosis in order: chronic obstructive pulmonary disease COPD, idiopathic pulmonary fibrosis IPF, cystic fibrosis CF, alpha 1 antitrypsin deficiency, pulmonary arterial hypertension, other diffuse parenchymal lung disease such as sarcoidosis, lymphangioliomyomatosis, Langerhans cell histiocytosis, collagen vascular disease related lung disease, bronchiectasis, pulmonary hypertension secondary to congenital cardiac disease as Edinger's syndrome. Indications of lung transplantation. The referral for transplant assessment should be considered in patients with progressive and advanced lung disease who are deteriorating despite maximal therapy, with poor quality of life, and or whose predicted 2-year survival is below 50%. Candidates should be functionally disabled but still able to walk, with no significant untreatable cardiac, renal, or hepatic impairment. They should have completed pulmonary rehabilitation. Disease specific guidelines for referral are as follows: COPD and other obstructive lung disease. The criteria are FEV1 below 20% predicted, and either total lung or lung total transfusion of the lung to carbon monoxide below 20, or homogeneous distribution of emphysema. The median survival 3 years with medical therapy. History of hospitalizations for exacerbation associated with acute hypercapnia PaCO2 more than 6.5 kPa and worsening hypoxia, pulmonary hypertension or cor pulmonale, the BODE score more than 7. Idiopathic pulmonary fibrosis criteria for lung transplantation include the following: any of lung transfusion for carbon monoxide below 40% predicted with clinical deterioration, fall in lung transfusion for carbon monoxide more than or equal to 15% over 6 months, fall in forced vital capacity more than or equal to 10% over 6 months, auto saturation below 88 on 6-minute walk test, acute rapid deterioration preceding the diagnosis. The criteria for cystic fibrosis and bronchiectasis for lung transplantation include the following: FEV1 below or equal to 30% predicted, or FEV1 more than 30% with rapid progressive deterioration, as for example, increasing exacerbation frequency, rapid fall in FEV1, history of intensive care unit or high dependency unit HDU admission for pulmonary exacerbation, autodependent respiratory failure, hypercapnia, or pulmonary hypertension, severe hemoptysis despite immobilization, pneumothorax in association with advanced disease, young below 20 years, female patients with rapid deterioration have a poor prognosis and should be considered for early referral. Pulmonary arterial hypertension criteria for lung transplantation. World Health Organization functional class 3 or 4 despite parenteral therapy for 3 months, worsening right heart failure with increasing fluid retention despite medical therapy, declining 6-minute walk test to below 3, 350 on despite 350 meter despite medical therapy, need for continuous intravenous inotropic support, mean right atrial pressure more than 15 mm mercury, and the cardiac index below 2 liter per minute, per meter square on right heart catheter despite optimal therapy. The timing of referral. This can be difficult. Predicted survival should be this the time of referral the timing of referral. This can be difficult. The predicted survival should be below 2 to 3 years, but patients must be fit for the procedure during a waiting time for typically 12 to 16 months in the United Kingdom. Allow time for thorough transplant assessment and the patient education. Early discussion with the transplant team is preferable. The referral decision should not be based on a single factor rather than a combination of clinical, laboratory, and the functional assessment together with individual patient trajectory should be considered. Patients with patients with IPF and CF have particularly high waiting list mortalities and early referral should be considered. Consider referral and diagnosis for suitable IPF patients with rapid symptom or rapid symptomatic decline, patients of shorter stature with blood group O have longer waits and a higher waiting list mortality in the United Kingdom and should be considered for earlier referral. Urgent super and super urgent lung allocation schemes. These schemes were introduced in the United Kingdom in 2017 in an attempt to reduce waiting list mortality. They aim to identify patients who are at high risk of death without transplant for prioritizations at national level. Urgent patients are suitable candidates for transplant with predicted survival below 90 days, including patients with high oxygen demand, e.g., more than 10 liters per minute, refractory right heart failure, and/or continuous non-invasive ventilation. Super urgent allocation applies only to patients suffering acute deterioration requiring extracorporeal life support, the ECMO, who have already been assessed and accepted onto a lung transplant list prior to their deterioration. Suitable patients with an acute decline and good rehabilitation potential who are already listed may be considered for bridging to transplant with awake, ideally ambulatory ECMO. Patients with sepsis, extrapulmonary organ failure, or requiring for intermittent positive pressure ventilation are excluded or delisted. Contact closely with transplant center. What are the contraindications for lung transplant? The contraindications include absolute, although occasional exceptions may occur, include severe and treatable extrapulmonary organ dysfunction, including renal, hepatic, and cardiac disease, solid organ or hematological malignancy within 5 years of listing, excluding cutaneous squamous or basal cell carcinomas, unstable critical condition such as sepsis and shock, uncontrolled extrapulmonary manifestations of systemic disease, severe and treatable psychiatric illness, basal metabolic or body mass index more than 35 per kg per meter square, active or recent within 6 months subacute addiction, cigarette smoking, alcohol abuse, illicit drug use, significant chest wall spinal deformity, no adherence with treatment or outpatient follow up, a lack of social support sufficient to compromise post transplant outcome. The relative contraindications include age more than 60 years, not an absolute exclusion but will be assessed by transplant multidisciplinary team in context of other relative contraindications, chronic medical conditions that are poorly controlled or associated with target organ damage, such as hypertension, diabetes, coronary artery disease, chronic renal disease with glomerular filtration rate below 50 milli per minute, severe or symptomatic osteoporosis, severe obesity, body mass index more than 30 kg per meter square, or malnutrition such as body mass index below 17 kilogram per meter square. Poor rehabilitation, potential sarcopenia and frailty, mechanical ventilation excluding non-invasive ventilation, chronic high-dose prednisolone more than 15 milligram per day, extensive pleural thickening, e.g. from infection or prior surgery or pleurodesis, colonization with Burkholderia, Synoviasia, or other higher resistance pathogens, previous cleared infection with Mycobacterium abscess is a relative contraindication. A minority of centers may transplant patients with active Mycobacterium abscesses disease, but post-transplant recurrence of Mycobacterium abscess is associated with very poor outcomes. Aspergilloma with extensive cavitation, and chronic extrapulmonary infection such as HIV, hepatitis B and C. Investigations prior to referral for lung transplantation. Important investigations include full pulmonary function tests and tests of exercise performance, such as 6-minute walk test, sputum microbiology, and electrocardiogram ECG, echocardiogram, the high resolution computed tomography HRCT chest, blood group, liver function tests, viral serology, human deficiency virus HIV, cytomegalovirus, hepatitis B and C, 24-hour creatinine clearance, and in select cases, stress echo and the coronary angiography include in the referral letter details as to the patient's understanding of disease and the prognosis, information regarding individual patient disease trajectory, e.g., serial lung function measurements, exacerbation frequency, and the severity over time is particularly valued by transplant center. The assessment process following referral patients and the family members carers typically attend a pre-assessment outpatient clinic which is followed by a 2 to 4 day inpatient assessment for potential candidates. Following transplant, MDT discussion, a listing decision is then made and discussed with the patient. What is the management of patients on waiting list? Patient on waiting list may receive management as follow: maintenance of nutrition, which may require supplementary feeding, avoidance of obesity, maintenance of mobility, continuing exercise and rehabilitation, monitoring of comorbid disease such as heart, kidney, liver, bones, optimized treatment of diabetes, systemic hypertension, osteoporosis, peptic ulcer disease, gastroesophageal reflux, sinus disease, psychological and social support, symptom control, such as palliative care input, is often required and should be considered in parallel with active treatment for patients on a transplant waiting list, prompt treatment of exacerbations, early non invasive ventilation if indicated, avoiding intubation if possible. What is the surgical approaches, follow up, outcome, and future developments? The surgical approaches, follow up, and outcomes, future development will be discussed in the next video.